essentially we found a specific pathology because of a large ovarian cyst which was responsible. And what we'll do in this perspective is try to discuss about various scenarios in which different forms of this peripheral precocious puberty presents. How is it different? What sort of evaluation is required, and how do we manage about this? This was a 3-year-old girl who presented with vaginal bleeding. She had thelarchy within 2 weeks, stage 2 breast development and pubic hair, and she was not very tall in that regard. So this is a very, very unusual scenario. Normally we talk about how there is a gap of approximately 1 year between the onset of thelarchy to the progression as far as the vaginal bleeding is concerned. Now, in this scenario, what we are seeing is that there is just some breast development which has happened in the last 2 weeks. And since then, you have a vaginal bleeding, which suggests that this is an extremely hyperestrogenic state. So estrogen becomes too high, the breasts don't get time to progress, and you have got vaginal bleeding. Now, vaginal bleeding typically happens when there is a withdrawal. So usually it means that the cyst now is not forming a very high level of estrogen. So your estrogen levels are coming down, and now the bleeding happens. So this is what was assumed in this case. There were no features of cafe au lait spots or rickets, and the parameters which showed that the LH and FSH was undetectable, and estrogen levels were reasonably high at that point of time. Now, what I'm trying to say is that this is the phase when your estrogen is weaning off. So probably this is the time when this 43 estrogen, which is very high for this girl, the levels would have been even higher, going up above 100 also in many scenarios of peripheral precocious puberty. So this was a classical case, and it was found to have an ovarian cyst which was detected. Now, the big question here is what to do from here. So most of us thought that, okay, there is no other clinical features of hypothyroidism, no features of McCune-Albright syndrome. So let's reassure this girl and just follow up on that perspective. But what happened that she presented a couple of years later with a trivial fall resulting in fracture, which was attributed to a fibrous dysplasia, which was developed. Now, there are no other clinical manifestations of McCune-Albright at that point of time, yet she actually behaved like McCune-Albright in that perspective. So this really highlights that even if you have an isolated ovarian cyst, if it's happening at a very early age, you have to think of a genetic cause. And I always say if you have a severe, syndromic, soon, or segregating etiology, these are the 4 conditions where genetic causes have to be considered. And McCune-Albright is essentially a somatic disorder. And when you talk about a somatic disorder, the manifestations will depend upon how many cells are affected. So you may or may not have the entire spectrum, which is there in that perspective. So what we'll try to do over the next hour or so is try to cover 4 of very interesting cases and how they differ and make appear similar also in various perspectives to go from there. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources regarding pediatric endocrinology, including courses, online courses for fellowship and diploma programs. We do run a number of monthly programs like our lecture series for postgraduates, for grand rounds, and these programs try to cover the entirety of pediatric endocrinology over a 2 to 3 year period from that regards. Our mobile application helps guide, evaluate, assess, and manage conditions along with our publications, both basic and advanced pediatric endocrinology. And just recently, last month, we brought out this pediatric endocrinology protocols, which covers the various aspects of evaluation and management. Now, what we're going to do over the next hour or so is try to cover 4 cases. So we have got an infant with ovarian cyst, which initially Dhwani will talk about. Then we have cyst with cystic lesions, skin lesions, young girl with ovarian cyst, and finally a girl with short stature and ovarian cyst. Before we do that, we will have a look with regards to a basic understanding of what we are talking about before we go ahead deep in terms of individual cases. So when we talk about puberty, we know that there are 3 major organs which regulate the pubertal onset: the hypothalamus, which produces the GnRH, the pituitary, which produces the gonadotrophins, and the ovary, which produces the estradiol. Now, within that, we typically classify this into a central form of precocious puberty, where you have got a high level of gonadotrophins. It's more of a concordant development. Typical gap between thelarchy and vaginal bleeding is around 1.5 to 2 years. If it's less than 1 year, we start thinking that it doesn't look like a central precocity, and then mostly it's idiopathic. While peripheral precocious puberty is more like a ovarian estrogen production, characterized by hypogonadotropic scenario, low LH-FSH, discordant pattern. Like in the first case, you had got a breast development and suddenly you have got the vaginal bleeding. So if you have a history that, okay, last 1 year, there was breast development and now bleeding happens, this looks more like a central precocious puberty. If you have no breast development and you have a bleeding, this looks like a local cause. But if you have some breast development and yet you have got bleeding, this discordant pattern suggests a peripheral precocious puberty, which is usually more likely to be pathological. Now, there are various causes which can cause the central precocious puberty, which will include effects like tumor, radiation, trauma, any insult will cause that. But most of it is 95% will be idiopathic. So beyond 6 years, we do not want to do unnecessary evaluation in the form of an MRI to identify a lesion. There are rare genetic causes which may also be there in that regards. Now, what our focus is most towards this aspect of the algorithm. So we'll talk about largely about McCune-Albright syndrome as a possibility. Hypothyroidism, we all know the TSH, when the levels are very high, is going to act on the FSH receptor to cause this development. Rarely you can have an estrogenic adrenal tumor, which can cause that. So within the scheme of causes of precocious puberty, we'll be focusing about the peripheral precocious puberty, which will include ovarian, and we'll focus pretty much all these three as a group. And then you can have rare scenarios like aromatase, excess, or exogenous or Peutz-Jeghers syndrome as a form. So functional ovarian cyst is a very common finding, which is basically means that your dominant follicle has become bigger and it's producing estrogen, and it's usually LH independent. Now, the course is usually fluctuating and often it's a one-off phenomena. I'll talk about that as to if you have a single isolated cyst, whether you need to worry about genetic causes or not. That's an important issue. But mostly it's a single event. It will not happen repeatedly if it's just a functional cyst. And you will have a high estradiol levels, which will be there in that regard. So management largely is observation, and we'll talk about criteria when you need to worry about and when you can think of torsion or malignancy as a possibility. So a cyst which is less than 10 centimeters typically, who doesn't have a solid cystic area, does not require a surgical intervention. You can manage it conservatively. Granulosa cell tumor is exceedingly rare, but it is known to occur in children. So it's basically will have a very rapid production. Your estradiol levels will be sky high. So if you talk about a cyst, so what happened? There was a cyst, there's some bleeding, some breast development, and then regresses. Here it will be a continued process. It will continue to grow from that perspective. Your estradiol levels will be very, very high, and you will have other markers which will be produced. So if you have a granulosa cell, it's going to produce more of inhibin, AMH, all other factors will come from there. And you may also have tumor markers which are being produced. So this is more like a ovarian estrogenic tumor. Very rare, but if you have very rapid estrogenization, which is persisting, and you have a large cyst which has a solid cystic area, start worrying about this condition. Really, management, of course, is cumbersome. You will require gynecological referral, surgical intervention, and further management will come from there. Now, one important condition which we'll be discussing today is the McCune-Albright syndrome, which is basically a problem in the GNAS1 region. So the GNAS is an important part as far as the cyclic AMP pathway. As far as the reproductive phenotype is concerned, this is because of overexpression or overfunction of the LH and FSH receptor, which basically will act on the ovaries to produce breast development, which will happen early, and you will have this discordant menarchal level. Again, the estrogen levels will become very, very high. Importantly, because you do not have much effect as far as the adrenal axis, you will not have pubarchy. They will present purely with a vaginal bleeding and some breast development. Because of very high FSH receptor expression, you will have large ovarian cyst. And the typical pattern is that, okay, you have got development now, you have got bleeding, you see a ovarian cyst, then the ovarian cyst regresses. There is a period in which there is no significant development, and then the second cyst appears. So it's like in the somatic areas where you have a problem in the ovaries. Now, this is a somatic defect. So not the entire ovary is affected. So it's not behaving like a testotoxicosis. Now, if you talk about testotoxicosis, that is a LHCG receptor activating mutation. So the entire testis is producing a huge amount of testosterone. This is not working like a ovotoxicosis. This is like certain cells in the ovaries, certain of these oocytes or the follicular cells will be starting to become more active. And so time and again, some of them will be selected and they will start producing. So it's a off and on waxing and waning phenomena, which is common in the setting of McCune-Albright syndrome. Now, TSH, of course, there are many other hormones which act through the GNAS pathway. So in TSH, it will cause thyrotoxicosis. You will have growth hormone excess causing acromegaly in certain scenarios. You may have a ACTH independent Cushing syndrome scenario. Skin lesions, of course, which are very, very important, are again because of the melanocyte stimulating hormones. So MSH hyperactivity in certain regions will cause pigmentation, and you will have bone abnormalities in the form of hypophosphatemic rickets like scenario, or you may also have a scenario of fibrous dysplasia. So the classic description of McCune-Albright syndrome, which is imprinted in most of our minds, is a combination of peripheral precocious puberty along with café spots and fibrous dysplasia. Now, what you need to remember is that this is a textbook description, and in real life, the patient has not read the textbook. So they will not come to you with these three complaints that I have got McCune-Albright because I have got an ovarian cyst, I have got a café spot, and I've got fibrous dysplasia. They can come with multiple varying manifestations. They may just come to you with isolated fibrous dysplasia, which is a very, very common, most common presentation, I will say. So you will have bony lesions, some bony swelling, especially in the skull areas, in the hand. There may be a trivial fracture. So you have to keep your eyes and ears open that, okay, this could be a fibrous dysplasia. Think of McCune-Albright in that regards. They may present to you just with recurrent ovarian cyst, where there is no other manifestations which are present that you have to be worried about. Similarly, in scenarios like macronodular adrenal ACTH independent macronodular disease, you have to think of a possibility of McCune-Albright. Any child who has got growth hormone excess, McCune-Albright is a strong possibility. Any child with hypophosphatemic rickets, think of McCune-Albright. So you don't need to have the entire combination. Even a single manifestation becomes important. I'll talk a bit about criteria about McCune-Albright a bit later, subsequently. So this is a somatic defect, variable and fluctuating course, and you may also have a secondary central precocity. Now remember, it's a defect which is there in the GNAS pathway. So what's basically happening is that your pathway continues to be active because the GTPase action is compromised. So the whole process of cyclic AMP is continuously being produced in that regards. Now this defect may not be present in the whole blood because it's a somatic one. So often most of the tests are not able to detect this, and this becomes important from that regards. What about hypothyroidism? So uncontrolled hypothyroidism will cause a very high level of TSH, which will act on the FSH receptor to cause large ovarian cyst, because there is a structural homology between the TSH, FSH, LH, HCG, and we have discussed this in many details. And this will cause large ovarian cyst. They may go up to 8 centimeters, 10 centimeters. I've seen cases who have been referred for surgical management, but then they are found to have hypothyroidism in that regards. They will have breast development. They will, of course, have vaginal bleeding, but they will have a delayed bone age because of the hypothyroidism primarily, and very importantly, because of hyperprolactinemia, they will have a low level of LH. So high apparent FSH activity, which is going to cause more ovarian stimulation, and low level of LH will basically mean that you have got no amount of puberty. So again, if you compare this scenario to a boy who presents to you with a severe uncontrolled hypothyroidism, they will again have the same scenario: large testis and no pubic hair. Similarly, large ovaries and no pubic hair. So effectively, von Wieck-Grumbach syndrome, as the term is called, is similar in manifestation in both boys and girls. It's just a matter of how they present. Depending upon menarche, you will get it much more easier in girls. In boys, as I said, FSH is a minor player. So high FSH will do nothing. It is not going to cause any change. It will only cause increased Sertoli cells, causing more testicular size from that regards. Again, no puberty is there. Rare scenario, which is similar to manifestations as far as macunal bed is concerned, is Peutz-Jeghers syndrome. It's a problem. It's considered to be a neoplastic disorder, part of endocrine neoplasia syndrome. So it's the STK11. Again, this is going to cause more cellular growth. So all of these are causing more cellular growth. Manifestations are ovarian sex steroid tumors, which may again cause precocious puberty, which will be peripheral in the form. And very importantly, you will have pigmented lesions, which are there in the mouth, like lentigens. I'll showcase one of my papers, which I've done in Australia, which showed that MAS may also have these form of lentigens, and they may also cause gastric polyps. So there is an overlap between STK11 and GNAS1. So these are like all the growth pathways which are going to be stimulated. Subsequently, we'll discuss about that. Aromatase excess, extremely rare scenario. Again, it will cause precocious puberty. You will have high levels of estrogen and you will have increased growth and bone age in that regards. Now, when should you think of a peripheral precocious puberty? So basically, if you have a very simple traffic as it's going like this, it's a concordant pattern, it's more likely to be a central precocious puberty. But if you're traveling somewhere in Kanpur or something where you find such a bizarre sort of a traffic and everybody is going here and there, you think of it's more like a peripheral. It's like a organized chaos. That's what peripheral precocious puberty is. So it's a fast and discordant pattern of peripheral precocious puberty. Of course, the most important tests are gonadotrophins, and we all talk about the importance of LH, which is much more important compared to FSH. Invariably, if you think of central precocious puberty, your LH FSH will be 0. Anybody who has a high FT4 should have a 0 TSH. Anybody whose cortisol is high should have a ACTH, which is undetectable. Similarly, if you have very high estrogen, you expect your basal LH to be less than 0.1. So generally, you are not in much doubt, but you can do a GnRH stimulation test if there is a confusion. You give a triptorelin or you give leuprolide 20 microgram per kg, 100 micrograms, and then you check your LH levels after 0, 2, and 4 hours, and you will find that there is lack of response, which will suggest that this is a peripheral precocious puberty. For me, a very high estrogen level and an undetectable LH is pretty good enough. You then have to go for imaging in that regard. So what you do is that if you have complete development and your LH is prepubertal, you have to go for peripheral precocity and go for imaging.
I had a 2-year, 6-month-old girl who presented to us with fresh bleeding per vaginum for 1 day. History-wise, the mother told us that she had noticed chest development for the last 10 days. However, they had not noticed any hair growth in the axilla or pubic area, and she gave no history of a rapid height gain noticed in the child in the recent past. So just by the history of it, it looks like a peripheral precocious puberty that has happened in this girl, and the most common causes that one would consider in a 2-year, 6-month-old girl would be trauma, vulvovaginitis, and ovarian cyst. So we went on to take the history further, and we were told that the child comes from a joint family, is always under supervision. So the history of the likelihood of a trauma or an abuse becomes less likely.
Would you think of trauma or a sexual abuse in this scenario?
Not really, sir, but especially with the chest development, it is.
So I think that's a very, very important giveaway, that you have got some breast development which happened, and subsequent to that you had a bleeding. So it's not that it's absolutely absent. So those becomes less likely. So yes, you talked about ovarian cyst as a possibility. What would be a close differential to this scenario? When you have some breast development and you have got bleeding. So ovarian cyst. Now, ovarian cyst, I mean macunal bed, hypothyroidism, functional, everything comes into one group. Now, what would be the other cause which can cause similar symptoms?
And exogenous estrogen exposure must be.
Yes, so I think that is something which is extremely important, and we see very commonly in the setting of the labial adhesions, when people will be applying these estrogen, and then you will have some immediate breast development and bleeding which may happen.
There was no history of local itching or redness noticed by the parents. She had no history of lethargy, constipation, or any other feature suggestive of hypothyroidism. There were no large birthmarks noticed by the parents, and there was no history of fractures. Because the history was unreliable, we also tried to look for the central causes. Parents gave no history of headache or laughter spells in the child.
That's a very important point. You mentioned that you're thinking of a central possibility. So is it possible, like we have said that you have got a gap between elarchy and menarche of around 1 year typically. Can you have a closer gap than that in central precocious puberty?
In rapidly progressive cranial lesions, we may have
so very importantly, if you have something like a hypothalamic hematoma, which is large, you will have such a high level of estrogen. So again, you will get more than this. You may go up to B3, but I've seen B2, B3, and then you have got periods. Still, you have got a possibility of a central precocious puberty. So just because your gap is less than 1 year, especially in a young age, does not effectively exclude. Now, can you have ovarian cysts? Suppose you say, okay, I've done ultrasound which is ovarian cysts in this scenario. Does that exclude central precocious puberty? No, in this case, 2 year, 6-month-old girl, you find the ovarian cyst, you have not looked into LH at this age. Does the presence of ovarian cyst exclude central precocious puberty? No. And then why do you, how do you explain ovarian cyst?
Because it could be due to the initial therapy effect of the increase in the LH, it could increase the FSH in the initial and could increase the initial estrogen.
Okay. What do you explain?
yes, the central one. If it is a
So
central,
ultimately, ovarian cyst can happen because of the gonadotropin stimulation also. So what I'm trying to say is that just because you find an ovarian cyst in ultrasound, that does not exclude a central cause, because as you see, so many girls later on will have functional ovarian cysts. This is all because of gonadotropin dependent one. So that is important. Carry forward.
moving on to the examination, her weight and height were essentially at the 50th centile for age. Her SMR showed a B2 to B3 staging with pubic hair stage 1 and fresh bleeding for vaginum was seen. There was no thyromegaly. These are the two tiny caphole spots that we could visualize. The one on the abdomen was really faint, but again, it was in the midline and the other lesion was on the right arm.
So what is the pattern of caphole spots? What number will be significant? What size will be significant?
Usually the caphole spots seen in McCune-Albright syndrome are associated with the midline. Lesions more than 5 are significant. Size may vary. Although classically larger size macules are seen in McCune-Albright syndrome, however, it is a spectrum and one smaller lesions have also been described in McCune-Albright.
So this is not leading us to anywhere, but it may suggest that there may be some McCune-Albright as a possibility. But this is not strongly favoring that. Usually you will have much larger caphole spots. They will have a very irregular margin. So margin is a bit irregular, which you can see on the left one. But generally they will be much larger from that perspective. So theoretically, McCune-Albright is possibility, but becomes less at the moment. Yeah.
On pervaginal examination, the mucosa was pale and no signs of trauma or foreign body was
So
seen.
there was a brachymetatarsia. Can you link it up?
It was familial. It was seen also in the
What is brachymetatarsia and how common is it without pseudohypoparathyroidism or Turner syndrome?
So, generally, brachymetatarsia is linked with the SOX defect and it is not linked to the McCune-Albright.
But yes, many normal individuals also, if you see carefully, will have brachymetatarsia. So if you talk about it being a sensitive marker of pseudohypoparathyroidism or Turner syndrome, it will be, but it will not be a specific marker. In that, many normal girls will also have those manifestations. So this is not fitting into, but yes, you are able to pick it up. That's important from that regard. So it won't change that management much. So what we're looking at is that there's only breast 2 to breast 3 and you've got vaginal bleeding. So it's a very, very significant discordance which we are seeing here. Carry forward.
Examination revealed an LH-FSH of 0.3 and estrogen level that was not very high. So maybe this was in the falling, the level was done
So
when
this
it
is a very, very important pattern again. That bleeding had happened how many days before?
When they came to us, it had happened for 3 days already.
And it had stopped by the time they
No, she was still.
So generally, when you talk about estrogen bleeding, the bleeding may happen if your estrogen level is continuously high and your endometrial thickness becomes too huge. And then you will have that the peripheral areas will shed. But the other way is that when your estrogen level suddenly falls, it's not sustaining the endometrium, but will decrease. So this could be a withdrawal bleeding, which we are looking at.
Her thyroid profile was in the normal range. Calcium and phosphorus were also again in the normal range, making macroalbumin less likely, considering that there was no thyrotoxicosis or hypophosphatemia. Ultrasound of the pelvis showed a uterus that was in the pubertal range at 3.5 by 1.4 by 1.6 centimeters. There was a large left ovarian cyst, which was hypoechoic and 2.4 by 2.3 centimeters. The right ovary was normal in size, and there was an endometrial thickness of 8 millimeters seen in the child. So
suppose you have got a scenario in which you are expecting active cysts like this. What is the expected estrogen level?
Usually more than 40, more than 100 actually.
So if the levels of estrogen are more than 100, it's not central, it's usually peripheral. So what is clearly shown is that there is an estrogen effect, there is some breast development, there is a pale mucosa as you were mentioning, there is ET thickness of 8 mm, which is very, very significant. And in fact, the uterus is also seemingly quite big for this particular age. So there was this cyst which was there, which was producing estrogen. But now probably it's coming down, and that's why all the levels are not very high. And LH is 0.31. How do you interpret that as at this age? 2 years, 4 months.
0.3 years. For just 2 years, we take the cutoff of 0.3.
So it's central then? So how do you explain this 0.3?
How do we explain? Okay, so in the estrogen withdrawal stage, there may be some increase in the LH.
If your levels of estrogen were very high, you may be suppressing the LH to a 0 level. And when it comes now, it's like a resurgence. It's like you have got this sick euthyroid syndrome, that in the initial phase, your TSH is low. When you are recovering, your TSH is going high. So I would not really bother about this. If you talk about, let's say, anybody who has got hypothalamic hematoma or some organic cause of central precocious puberty, the LH levels in that case will be 6, 7, hugely high. It can't be this level of LH. So again, if you just interpret this, this is just a rebound phenomena. So I wouldn't be too bothered about that phenomena.
We'd also planned GnRH stimulation in this case, but it was somehow not done.
It was probably not required.
Yeah. Moving on, the skeletal survey done to look for fibrous dysplasia was normal, and
So essentially now you have got a scenario which looks like a functional ovarian cyst in that regards. So what is the likelihood of this girl having macroalbumin? Now that's a major question that is to be there. You excluded hypothyroidism. What is the likelihood of this girl having macroalbumin and a estrogenic ovarian tumor?
For an estrogenic ovarian tumor, the ultrasound findings should have shown a solid cystic lesion. A purely hypoechoic cyst makes the possibility of a granulosa cell tumor less likely. She could still be an evolving macroalbumin because I'm not sure of the exact percentage, but a good percentage of macroalbumin presented with ovarian cyst and then went on to develop other features of.
How common ovarian cyst at this age? So ovarian cyst, contrary to popular belief, can happen even antenatal.
Yes.
People have seen many girls who develop antenatal ovarian cyst, and they're very common because ultrasounds are not done routinely. You and many girls who come to you with isolated breast development, some development for some time may have had this sort of a thing. Their estrogen was not high enough. So this is not very uncommon. So I talk about one study in which they really looked at in terms of isolated ovarian cyst and genetic causes.
Yes.
So if you have a single cyst with no extra ovarian manifestations, we are justified in observing and not doing undue work. But the only thing is that this is a young girl, so we need to be more cautious. The chance of macroalbumin will be much higher. When we talk about the older girl, there the chances will be even less likely in that age.
So functional ovarian cyst, the incidence of ovarian cyst in general is 2 to 5% in prepubertal girls, and among these autonomous ovarian cysts,
5% is huge.
Yeah.
Which means that so many girls will be roaming around with ovarian cysts.
And among these 2 to 5%, about approximately 5% have autonomic functioning ovarian cysts. Usually a diameter of more than 9 millimeters is suggestive of an autonomic function. And although the cutoff is of more than 9 millimeters, usually these cysts have a size of 2.5 to 5.5 centimeters. They are usually isolated. They develop and regress spontaneously. And often bone age is not advanced with functional ovarian cysts, even those that are recurring again. The common differential diagnosis that we've already discussed with granulosa cell tumor, McCune-Albright, and hypothyroidism must be looked for in these patients. Management-wise, as sir has already mentioned, these are often self-limiting and a conservative approach is beneficial. However, 40% may have a chance of recurrence. And with if these cysts keep on recurring because of intermittent rapid high dose of estrogen exposure, there may be a central trigger of precocious puberty, and in such cases, cytotrione acetate, third generation aromatase inhibitors like anastrozole, letrozole have been tried. Even estrogen receptor agonist tamoxifen has been used. GnRH agonists can be used for a central triggered precocity, but one must remember that it will not prevent recurrence of an ovarian cyst in these scenarios. Surgery is indicated only with a very large size, as sir has already mentioned, where risk of torsion is very high, where there is rapid development of secondary sexual characteristics and persistence of cysts for more than 3 months. So, although there are multiple studies that have shown case series of isolated functional ovarian cysts, the pattern is much similar as the current study that I'm showing here. So if we look at it, yes. In the series of 11 patients, 3 had an onset at ovarian cyst diagnosed even in the prenatal period, and the rest of them had around 2 to 5 years, 2 to 9 years of age occurrence of ovarian cyst. Recurrence was seen in almost 4 of these patients, so about 40%, as we've already seen. Out of 11, about 4 had recurrence in later stages of life. In the index child, she bled for about 5 days with intermittent spotting. Follow-up at 2 weeks showed a regression in breast stage and soft breast, suggesting that the estrogen exposure had waned off. And we plan to closely follow her up to look for recurrence.
Usual scenarios which can often happen with McCune-Albright as well. This is one of our publications which I published from RCH Melbourne. And this is a very interesting scenario in which we are seeing overlap between Peutz-Jeghers syndrome and McCune-Albright. So these are these 4 boys, and there were a couple of boys and a couple of girls. All of them had got very peculiar lentiginous-like pictures. So they were behaving like Peutz-Jeghers. They were found to have a gastric polyp. And this basically suggests that MAS, the involvement may be very wide. And we need to be cautious about development of other tumors as well. We also identified that there are platelet dysfunctions which may happen in the setting of McCune-Albright, which we need to be cautious. So the classical phenotype of TSH, GHRH, or ACTH or MSH is much wider as far as McCune-Albright is concerned. You can have, of course, café au lait spots, large ovarian cyst, thyromegaly, thyrotoxicosis, along with thyroid nodules which may develop. You may have a growth hormone excess which may happen, and you can have multiple areas of involvement like skeletal dysplasia and fibrous dysplasia which may happen. So how do you diagnose? And this is the group which has done the maximum work as far as McCune-Albright is concerned, the NIH group. Now what they are saying is that you need to have 2 or more clinical features to reach the diagnosis. And the classical features are, of course, fibrous dysplasia is the most common, café au lait spots with characteristic features, gonadotropin independent precocious puberty, then testicular, thyroid, and other scenarios. So this is something which we need to be very, very careful about in that perspective. So they're talking about 2 or more as a criteria. But that does not mean that if you have a girl with recurrent ovarian cyst who is behaving like, can still have a GNAS activating mutation. Whether you call it McCune-Albright or not, doesn't matter. Now, this is what I was discussing about the café au lait spots. So Dhwani was describing about those small café au lait spots. So what they mention is hyperpigmentation with irregular border, distribution reflecting the midline of the body. So it's not the size, it's the pattern which becomes more important from that perspective, which was seen in this case. And now about diagnosis, the major problem is that this is a somatic mutation. So you may not be able to identify the scenario. So what they're saying is that if you take the blood, only 20 to 30% may be having a positive diagnosis on the blood. You may have a higher chance, approximately 80% if you take the lesion. So if you look at the ovarian cyst, the tissue, if you take the skin biopsy from the café au lait spot, if you take the fibrous dysplasia, you will get a much higher yield, but still your genetic diagnosis is not going to be 100%. So it cannot exclude. So what they have said is that if you have a positive result, it confirms McCune-Albright syndrome, but a negative result does not exclude the condition. And therefore, routine role of genetics is not going to be very significant. Your management is not going to change. If you have fibrous dysplasia, you manage it like that. If you have a peripheral precocious puberty, you manage it as a peripheral precocious puberty. If you have thyrotoxicosis, you manage like that. So it's not that if you don't find on genetics, you don't need to really think that, okay, we can't do anything. This is not McCune-Albright, importantly. Now, this is a very important question. If you have a prepubertal girl coming to you with ovarian cyst and you have excluded hypothyroidism, there are no other features, this looks like isolated, can it have a genetic etiology? Now, this was an interesting study which was done from the French group. Dr. Sultan was the main lead in that, and he had actually done studies about the prenatal ovarian cyst as well. And this was quite a long time ago in this scenario. So what they did was that they tried to evaluate for a number of genes which can potentially cause ovarian cyst. And they studied in these 11 patients. And what they found was that they did not find any of these mutations. The important ones are GNS1, LHCG receptor, of course, and FSH receptor, star. So all these defects they could not find. So what they're saying is that most of these isolated ovarian cysts are non-genetic in nature. So you don't need to worry too much, especially if you have a single lesion. So don't go ahead and worry about that. Of course, look clinically for a café au lait, look for the skeletal abnormalities, but you don't need to be too much bothered about reaching a genetic diagnosis in that regards. Now, how do you manage? Dr. Priyanka has already mentioned. So specific management would be at the level of either blocking estrogen production, like using aromatase inhibitors like letrozole, blocking the estrogen action, using a selective estrogen receptor modulator like tamoxifen or fulvestrant, which is an antagonist. Then if you have thyrotoxicosis, you use methimazole / radioactive iodine. GHRH, of course, it's a long-acting, it's a hyperplasia, so you can't do a surgery. So you have to think of a LAR or a pegvisomant group of drug which will be there. For ACTH, you have to use metyrepone or you can use ketoconazole. Rarely, you might have to need a adrenalectomy, which is there. And for fibrous dysplasia, pain, lesion size, and other parameters, zoledronic acid is the clear-cut treatment of choice from that regards. Rarely, if there is a secondary central precocity, you can use GnRH analog in that setting. As far as puberty is concerned, as discussed, aromatase inhibitor letrozole has been used, but it tends to increase the ovarian size and it is less efficacious. So we don't prefer letrozole as a primary therapy, and that is why in the case we shifted from letrozole to tamoxifen. We prefer tamoxifen, but there is a chance of developing ovarian cysts may become bigger, so you have to monitor that size in that perspective. And of course, the estrogen receptor antagonist fulvestrant has been shown. I'll show a study also to have a much more potent effect, but you need to give injection. It's a more expensive treatment, and that's why you need to be a bit careful about from that regards. So this study clearly shows that if you use letrozole, you will have improvement as far as the bone age is concerned, as far as the estrogen levels are concerned, but the ovarian volume may actually increase significantly. So the use of letrozole is not favored as a primary agent in McCune-Albright syndrome. Tamoxifen has been shown even to the final adult height that it results in a significant increment of height, and what they are saying, in fact, from 145 to 157. So it's as good as using a GnRH analog. So tamoxifen, and I find this case, we had a very good response. She had an onset of 1 year. So now at 10 years, if we are able to allow the delay in bone age progression, and if we are able to avoid central trigger, it's going to be working very well in that regard. But you have to tell them that this is need to be done on a daily basis. You can't just keep on giving and stopping, and then again things will happen. And there will be times when you have some cysts which are formed. You may have high estrogen at that time. You may treat at that time, but continue tamoxifen in that regards. Now, fulvestrant, and this is again a study from Dr. Sultan's group and Erika Eugester's group. And what they have shown clearly is that this is a good drug. The frequency of vaginal bleeding becomes much less. There is improvement in terms of bone age and other parameters as well. So this is a selective estrogen receptor 1, ES1 antagonist, or estrogen receptor alpha antagonist. Dr. Elizabeth is asking about estrogen levels in functional ovarian are high enough to cause breast development and bleeding, but do not accelerate the bone age. Dr. Elizabeth, this is related to the fact that the duration is also important. So it's not just how much your levels are, how long these levels are. So usually this cyst will regress in certain times. So it does not cause acceleration bone age, but if it's persistent like McCune, right, you will have a scenario in which it will increase. Dr. Bharani is asking what proportion of increase in bone age in exogenous estrogen versus McCune, right? Because I've seen girls with estrogen with raised bone age. Yes, so if you give exogenous estrogen at a very high level, of course, you will have a scenario in which you will have a very rapid development, which will happen from that perspective, and then bone age can really accelerate. So Priyanka, who is currently working as a pediatrician at Monilek Hospital in Jaipur, and she has been very enthusiastic participant in our MedEClasses sessions, and she'll be presenting a case which we managed jointly, a very interesting young girl.